Start the presentation.
So, good evening, respected doctors and panel members. Today, let us discuss a case presentation of ptosis. Presented myself, Dr. D. Swathi, third year postgraduate, SMC Medical College, Tirupati, and modern Dr. P.S. Chalapati Reddy, sir, HOD of the department, SMC Medical College, Tirupati. The Vamsika, 6 years old female child, residency of Tirupati, came to the OPD with a chief complaints of drooping of eyelid in both eyes since birth and inward deviation of the left eye since birth. History of presenting illness. The parents noticed the complaints of drooping of the eyelid in both eyes since birth, which is not progressive and not associated with any diurnal variation. Patient also complains the inward deviation of the left
Sorry
eye.
for disturbing you. Ma'am, your voice is too low, ma'am.
Swati.
Yes, sir.
Swati, start again.
Yes, sir.
Modulate your voice.
Okay.
And your voice is not very clear.
Okay, sir. So, good evening, respected doctors.
Okay, keep your
and respected
tab
panel
closer.
members. Let us discuss a case of ptosis present at Dr.
Yes, go
D.
ahead. Go ahead.
Swathi
Little louder.
myself, third year postgraduate, SMC Medical College, Tirupati. Moderator Dr. P.S. Chalapati Reddy, sir, head of the department, SMC Medical College, Tirupati. Vamsika, 6 years old female child, residents of the Tirupati, came to our OPD with the chief complaints of drooping of the eyelid in both eyes since birth and inward deviation of the left eye since birth. History of presenting illness. Parents noticed the eyelid in both eyes since birth, which is non-progressive, not associated with any diurnal variation. Patient also complains inward deviation of the left eye since birth, which was non-progressive, associated with tilting of the head towards right side, noticed after 1 year of age, not associated with defective vision and double vision. No variation in the amount of ptosis with extraocular movements or jaw movements. No history of worsening of ptosis as a day progress. No history of spectacle usage. No history of blend trauma. No history of double vision. No history of difficulty in deglutition. No history or tiredness. No history of any associated lid tumors, swelling, and recurrent allergic conjunctivitis. Past history, history of consanguineous is present. Birth history, normal vaginal delivery. The use of forceps or instrument is not known by the patient's parents. Family history, no significant family history present. Treatment history, no history of any systemic illness or any drug intake. Present is personal history, mixed diet, normal bowel and bladder habits, normal sleep and appetite. General examination, patient is conscious, coherent with time, place, and person, average built and nourished, slattering of speech is present, mild intellectual disability is present. Systemic examination, body weight is 12.5 kgs, pulse rate 82 beats per minute, regular in rhythm and normal in volume. Blood pressure 125 Hg, measured in left arm. Cardiovascular system, S1 and S2 is here, no murmurs. Respiratory system, clear, normal vesicular breath sounds. Lymph nodes, no regional palpable lymph nodes is present. Local examination, this is a photo of the patient. We can able to appreciate health is tilted toward right side, face symmetric with left eye 15-degree esotropia and right eye 15-degree hypertropia. Chin is up, elevated. Ocular examination, best corrected right eye, best corrected visual acuity, able to follow object and lights. Eyebrows, raised eyebrows due to the overaction of frontalis muscle. Eyelids, that's a drooping of upper eyelids.
975 to 140. 1100.
Eyelashes, normal. Palpable aperture, the vertical height is 8 mm and horizontal height is 28 mm. Inferior scleral show is present. Bulbar conjunctiva, muddy and papal conjunctiva is pink. Cornea, size and shape is normal. Surface clear and sensation is intact. Anterior chamber depth, PACD more than 3/4 of PCT and contents are clear. Hair is color brown and pattern is wavy. Pupil, size 3 mm, round in shape and reactive. Lens, clear and extraocular movements are full. Now let us see about the left eye. The best corrected visual acuity, able to follow object and light. Eyebrows, there is a raised eyebrows due to the frontalis overaction. Eyelids, that is drooping of upper eyelid. Eyelashes are normal. Papal aperture, the vertical height is 7 mm and horizontal width is 28 mm and inferior scleral show is present. Bulbar conjunctiva is muddy and papal conjunctiva is thick. Cornea, size shape normal, surface smooth, clear and sensation is intact. Anterior chamber depth, PACD is more than 3/4 of PCD and contents are clear. Iris, color is brown and pattern is wavy. Pupil, 3 mm in size, round reactive, lens clear. Extraocular movements, that will be restriction upward and towards right and overaction upwards towards left. These are the extraocular movements. Picture. So fundus examination, right eye media is clear, optic disc size shape is normal, color is pink and margin is defined. Cup and disc ratio 0.3:1. The vessels is normal, AB ratio is 2:3 and general background is normal. Foveal reflex also is present. Left eye media is clear, optic disc size and shape is normal, color is pink, margin is defined. Cup disc ratio is 0.3:1 and vessels is normal. Artery and vein ratio is 2:3. General background is normal. Macula, foveal reflex is present. So coming to ptosis examination, right eye. So marginal reflex distance 1 in right eye is 2 mm and marginal reflex distance 2 is 6 mm. So upper lid crease is absent and marginal crease distance, since this is absent, we can't able to measure it. So amount of ptosis is mild, so that 2 mm and levated palpable superior's function measured by using Berg's method is poor. It is around 3 mm. Lagophthalmus is absent. Relaxin and downwards gaze is present. Best foramen is fair. Telecanthus test is absent. Or transmission test is absent. Ice pack test is absent. Jaw brinking test is absent. Particularity is absent. Cohen Rich test is absent. On examining the left eye, a marginal reflex distance 1 is 1 mm and marginal reflex distance 2 is 6 mm. The upper lid crease is absent. The marginal crease distance 3 6 is absent. Ptosis, the amount of ptosis is 3 mm, which is moderate. The levated palpable superior's function measured using Berg's method is poor. So its amount for 2 mm. Lagophthalmus is absent. Relaxin on downward gaze is present. Bell's foramen is fair. Transformation test is absent. Ice pack test is absent. Jaw winking test is absent. Particularity is absent. Cohen Rich test is absent. So squint evaluation. The eccentric corneal reflex on the right side is 15-degree hypertropia. Cover uncover test, there is no deviation. The alternate cover test shows downward and inward deviation. On examining the left eye, 15-degree esotropia is present. A cover uncover test, no deviation. Alternate cover test shows inward deviation of the eye. So problem diagnosis will be right eye mild congenital ptosis with poor levator parallel superior's action, and left eye is moderate congenital ptosis with poor levator parallel superior's action. Now we can go for the plan of action. So combined surgery for strabismus and ptosis can be done. Since correction of strabismus may relieve the ptosis, strabismus surgery should be performed before the ptosis surgery. In case of cosmetically accepting strabismus, only ptosis should be treated. So choice of ptosis surgery depend upon the primary function of the levator. So based on this flow chart, we can able to see. So if the patient is having the risk of amblyopia, urgent browsing or frontalis link should be done. If amblyopia is not there, so we have to measure the levator function. If it is more than 10 mm, and we should measure the degree of ptosis. If it is less than 2 mm, personal servant surgery can be done. If it is more than 2 mm, aponeurotic surgery can be done. If it is less than 10, levator function is less than 10 mm, so we have to look for levator function more than 4 mm, levator resection can be done. And less than 4 mm, brow sling or frontal sling can be done. Thank you.
Hello, sir. Subramaniam, sir.
Any questions?
Sorry,
Yes, sir.
Sham, Dr. Subramaniam, sir, is around?
Yes, sir. He is there, sir.
Uh.
He is in mute, sir, actually.
Huh?
Yes, sir. He is there, sir. He is on mute, sir.
Sorry, Professor Subramaniam, sir, is also there. Yes.
On mute, yes, sir.
Sir, can you go ahead with second case, or will you please discuss, sir? Madhu? Okay, summarize the case, ma.
So, Vamsika, 6 years old female, a chief complaints of drooping of upper eyelid in
No,
both
no,
eyes since
no. Don't want the history. Just your diagnosis and what are the points to say that it is congenital.
congenital.
It's a congenital ptosis. Why it's congenital ptosis?
So, you can say upper lid crease is absent and LPS function is
Little
poor.
louder, and it should be clear.
So, upper lid crease is absent on ptosis examination, and levator papillary superior's function is also poor. And there is lid lag sign on downward gaze is present. So with these three things, we can tell it is a congenital ptosis.
Okay. Okay, can we have the next presenter? Sir,
Okay, sir.
Subramaniam, sir.
Hello.
Good evening, sir. Good evening, sir. Hi, sir.
Good evening. Hello, am I audible?
Yes.
Yes, sir. Yes, sir.
Okay. I'm sorry, I got deleted due to some technical reasons. Right. Okay, I have followed the presentation.
Sir.
I have followed the presentation from the beginning. You made a diagnosis
Sir.
of bilateral congenital ptosis with blepharophimosis and right hyper and left convergent
both
spleen.
the,
Is it correct?
it is both eye
I'm not able to
congenital
hear you,
ptosis.
ma'am.
Both
Yeah,
the congenital ptosis with poor levator
A little louder, please.
superior function.
Little louder
function,
and be closer to the mic, Swati.
both eye, the right eye is mild congenital ptosis and left eye is moderate congenital ptosis with levator papilla superior's poor action, sir.
Hello.
And sir is asking, is there a hypertropia in one eye and esotropia in the other eye?
Yes, sir.
Right. Okay, now, why did you say it's a congenital ptosis clinically?
The patient is having since birth, sir, and it also
Louder.
the patient is having ptosis since birth, and on ptosis examination you can able to see absence of lid crease, and there is a poor LPS muscle function, and also you will have lid lag on downward gaze, sir.
That is the best important thing. Lid lag and downgrade is the answer we expect from you. You say it is a congenital ptosis. Okay. You made a diagnosis of blepharophimosis with a telecanthus of 33 millimeters and a horizontal palpebral. No, let me complete, dear. Horizontal width of 28 millimeters. Right. Normal horizontal width is 28 to 30 millimeters. So 28 millimeters, if it is there, it is not phimosis. It's only vertical element that is reduced. 33 is not a telecanthus. What is the IPD? Interpupillary distance? What is the interpupillary distance? You haven't measured. I did not see it. I did not know that you have measured interpupillary distance. Okay? And fatigue test, Kogan's, which all these things are only for acquaintance, not for congenital ptosis. Then you made a mention that right eye ptosis is mild, 2 millimeters. Left eye is moderate. But you said the LPS action is 3 millimeters. Am I correct? With a 3 mm LPS action, you do not get a mild ptosis. It will be a severe ptosis. Probably you might not have made the eyebrow come back to normal position when you were doing and checked the CHF before you have recorded the MRD1 and the MRD2. With a 3 mm of LPS action, you don't expect a lid crease. You expect a severe ptosis, not mild ptosis. Okay? And you also said that correction of squint may improve ptosis. How does it so? Can you explain, elaborate on that point? Correction of squint can improve ptosis, that's what you said. Which squint you want to correct? Is it right hyper or left convergent squint?
Type.
I'm not able to hear you, ma'am.
Left eye, sir.
Right hyper. You said right hyper, not left
Left
hypo.
Left eye, sir.
When the right is hyper, why do you correct left? If the left is normal in position, how is the elevation?
Elevation is normal.
Then when the elevation is normal, left elevation is normal, it is not that the left superior rectus is weak. It's not monocular elevation defect. If it's a monocular elevation defect and Bell's is poor, you would like to correct that. Why do you correct the, what do you want to do to the left eye? And second thing is, what is the patient's age? Child's age?
6 years, sir.
6 years. Is the child not going to school?
Yes, sir, she's going to.
Then what is the visual acuity?
Our patient's baby is not cooperating.
And
Patient
at least
able
you
to
should.
follow the object and line.
No, that is, we don't agree in the exam. Say 6-year child, you have to get some visual acuity. When he is going to school, when the child is going to school, must be having fairly okay vision that you should be able to receive. And the second thing is you have the refraction, because congenital ptosis is associated with amblyopia due to anisometropia or myopic astigmatism. Right. If there is significant astigmatism that needs to be corrected, whether you are able to get the visual acuity done or not with the patient, you have to get it corrected. Okay. So what surgery how do you like to manage this case?
It's based on the levator, based on doses and the amount of levator muscle function. We have to proceed the case.
I don't
Little
want
louder,
theory.
Swati.
I don't want theory, Swati. Right. You have seen the patient. You know what is the LPS action, what is the amount of doses, you know everything. I don't want theory. How are you going to manage this case?
We can go for a levator resection or a
Not we, it's you.
We can go for brows frontal sling surgery.
For 2 mm and 3 mm?
But levator function is poor, so we can go for a frontal.
So you would like to go for
Frontal.
frontal slings with what?
Facial data is not completely developed.
At this age, facial data is tough. At his age, small child to get order such a big facial data is difficult, and we don't have access to stored facial data. A simple procedure may be RO sling, silicon sling.
Silicon.
What are the different types of doing this? What are the two more prominent facial data surgeries? The brow suspension surgeries. Crawford's methods of doing brow suspension surgeries.
Crawford's and Cross method.
Crawford's and
Cross method. Fox pentagon. Fox pentagon.
Fox pentagon. Fox pentagon and Crawford's. Normally you can do one of the two. Probably simpler is Fox pentagon. We can do that, and that will take care of bilateral. Okay, that you can do. And how about the convergent squint? How do you manage it? Did you do cover test?
Cover test, no deviation.
Cover test, no deviation. You said that there's a convergent squint of 15 degrees in the left eye. Yes or no? Go to the. Did you not mention that right hyper and left convergent squint 15 degrees search work? Go to the case sheet.
Share your slides again. That case sheet.
Case sheet once more. Esotropia, 15 degrees left eye.
Right eye is hypertrophic skin.
Right hyper, left E. So that's what I'm saying. That's what you have said. Did you do the cover test? You can see apart from the right head tilt to the right, chin is also up. Brows are up.
Yes,
So
sir.
you have to correct all these things before you do the MRD1 and MRD2. When the chin is up, eyeballs have rolled down. So then what happens? Aperture becomes a little wider, D1 increases, so that the child will be able to see. Unless you correct all these things before taking MR D1 and D2, you will end up with inconsistent and wrong results. Okay.
Okay.
What will you do for the left eye? Oh, did you do the cover test?
Yes, sir.
Is it a uniocular squint or alternating squint?
Unilateral. Unilateral squint, sir.
Uni?
Unilateral squint, sir.
No, you have shown in your picture. Is that a video? Cover test?
Yes, sir. Yes,
Yes,
sir.
show that to me, please. Do you know whether it is uniocular or alternating squint? Which test you will do? Cover and cover or alternate cover test?
Sir, I can't hear, sir.
Do you know whether it is uniocular squint or alternating squint? Which test you will do? Cover and cover or alternate cover test?
Alternate cover test, sir.
That's wrong. You have to do cover and cover test. That's why I'm asking all these questions. These are all the basics. Squint can be a long case for you in the exam somewhere. And unless you master cover test, you can be caught there. You have to read cover test and its interpretations.
Okay.
So you don't know whether the shell has amblyopia or not. The shell is not cooperative, you are saying. In that situation, you have to do a refraction and prescribe glasses. You do a bilateral brow suspension. If the Bell's is fake. Okay.
Okay, sir.
And then other thing is you can do is, if not Bell's, you have to do brow frontalis flap for both eyes.
Okay, sir.
That is other option that you have. And frontalis flaps for both eyes so that you get a symmetrical elevation. And then do the refraction after 2 months and prescribe glasses. Okay. Before that, you take care of, evaluate the squint. First, do the squint surgery. I don't want to spend time on squint because squint itself can be a long case for you. Okay. Right. So thank you. You have done fairly well. But these are the things that you have to have a clear. First thing you are doing is correcting the squint, then bilateral brow suspension or bilateral frontalis flap for ptosis, then refraction and prescription of glasses. Okay? All the best.
Thank you, sir. Thank you for giving me this opportunity to present. Thank you.
Thank Mathur and thank your HOD.
Sir, thank you very much, sir. It's a pleasure. Not Guru, sir.
Sir, right.
250, madam.
Can we ask the next presenter to present
Please. Oh,
the
yeah.
case, sir?
Oh, yes.
Good evening, sir. I am Dr. Sadhana, sir, moderator for next case, sir.
Okay, Amma, thank you.
Okay, sir. Shravani. Hello, Shravani.
Meeting.
Swati, stop sharing your slides.
Shravani?
Sadhana, Swati has to stop sharing her slides.
Okay, Chalpati.
The slideshow. Make it a slideshow, Shavani.
Good evening, sir. My name is P. Shravani, final year postgraduate from SV Medical College, Tirupati. My moderator is Sadhana, ma'am, associate professor.
Louder and close to the mic.
A 63-year-old female patient named Rangamma, who is a homemaker, came with chief complaints of drooping of eyelids in both eyes since 3 years. History of present illness. Complaint of drooping of eyelids in both eyes since 3 years. Insidious in onset, gradually progressive in nature. History of defective vision in both eyes for both distant and near vision since 6 months, which is painless, insidious onset, and gradually progressive. No history of double vision. No history of difficulty in swallowing of food. No history of alteration in amount of
Little
toxins.
closer to the mic and little louder, ma. It is not audible. It's not clear.
Shravani,
Yeah.
can I interrupt you in between presentation? Ask questions?
Okay, sir.
Okay, why did you ask for difficulty in swallowing of food?
Oculopharyngeal muscular dystrophy, sir.
Okay, okay. No, his
No
double
history.
vision?
Double vision in third no palsy.
Ma'am, can you do
Neurogenic
your
process.
presentation without earphones? Because in the your earphones, the voice is not coming.
Go ahead, please.
No history of recurrent allergic conjunctivitis.
Able to hear that.
Yeah,
Now it is perfect.
can
Just
hear better. Can hear
yeah,
you very well. Loud and clear. One thing. Yeah, go ahead.
Okay.
Hmm.
No history of headache. No history of head injury. No history of any ocular trauma. No history of previous ocular surgeries.
Anything that you missed in the
Past
history? Anything important that you missed in the history? Diurnal variations. Which is very important for acquired process. No history of diurnal variation is not there.
No history of diurnal variation, sir.
And that you have to mention, Amma, in the exams
Okay, sir.
for every acquired process. You
Okay,
have to
sir.
mention that. Okay.
Okay,
Will there
okay,
be,
sir.
what are the types of doses or different types of doses in which diurnal variations can be present?
Myasthenia gravis.
right?
As day progresses, ptosis worsen.
Yeah, myasthenia gravis is one condition. Any other condition with diurnal variations? Involutional ptosis. I am telling the answer. It is the second is involutional ptosis.
Involutional ptosis.
These are the two
Because
conditions.
okay.
These are the two conditions in which diurnal variations will be present. Okay? Right. Go ahead.
Past history. She is known case of diabetes mellitus since 4 months and she is on tablet metformin 500 mg OD. No history of hypertension, cardiovascular accident or coronary artery disease, CKD, thyroid, asthma, TB or epilepsy. No significant family history. Personal history. She takes mixed diet, normal sleep and appetite. Bowel and bladder habits are normal. Systemic examination.
One minute,
Cardiovascular system S1,
one minute. In a case of a acquired ptosis, in a younger individual, better socioeconomic status, you have to include history of contact lens wear also.
Okay.
That could also be a triggering factor for epidemiologic ptosis. That also you have to include in the history. Okay.
Respiratory
Go
system,
ahead.
bilateral vesicular breath sounds heard. Central nervous system, no neurological deficit. Local examination, head, chin elevation is present. Face bilateral symmetrical. Ocular examination, right eye, eyebrows is raised. Eyelids drooping of upper eyelid present. Eyelashes are normal. Palpebral aperture, vertical height is 4 mm. Horizontal width is 28 mm. Bulbar conjunctiva is muddy. Palpebral conjunctiva is pink. Corneal size and shape are normal. Surface is smooth and transparency is transparent. Sensations are intact. Anterior chamber depth, peripheral anterior chamber depth equal to half PCT. Contents are clear. Iris color brown. Pattern is wavy. Pupil size is 2 mm round and reactive. Lens is grade to NS and extraocular movements are full. Coming to left eye, eyebrows are raised, eyelids drooping of eyelid present, eyelashes are normal, palpebral aperture vertical height is 4 mm, horizontal width is 28 mm, conjunctiva bulbar is muddy, palpebral is pink, cornea size and shape are normal, surface is smooth, transparency is transparent, sensations are intact. Anterior chamber depth equal to half PCT. Contents are clear. Iris brown and wavy. Pupil size 2 mm round and reactive. Lens grade 1 NS. Extraocular movements are full. Fundus examination. Media right eye is hazy due to LS. Optic disc size and shape are normal. Color pink. Margins defined. Cuppist disc ratio is 0.3:1. Vessels normal. A is to V is 2 is to 3. General background is mild choroidal sclerosis. Macula is FR+. In left eye, media is hazy due to lenticular sclerosis. Optic disc size and shape normal. Color pink. Margins defined. Cuppist disc ratio is 0.3:1. Vessels normal. A is to V ratio is 2 is to 3. General background is mild choroidal sclerosis is present.
Whenever you are,
Macula foveal
one minute, please. Whenever you are talking about cup disc ratio, it is imperative to say the size of the optic disc, whether it's normal, big or small. Because the cup disc ratio, if it's a large disc, 0.3, rather we'll put it this way, if it is a small disc, 0.3 may be significant.
Okay, sir.
Right. So the C's to the cup disc ratio validity depends on the size of the disc. That you have to mention. So in a situation like this, if you say fundus normal, media clear, I would have been okay. If you were on this cup size, you have to write size is normal. Okay, you have mentioned size is normal. That's fine. Sorry, dear. It's my mistake. I did not see that. You have to mention the size. Okay? Right.
Visual acuity in right eye is 624 with pinhole no improvement. Intraocular pressure is 13 mmHg. Color vision and contrast sensitivity are normal. In left eye, visual acuity is 618 with pinhole, no improvement with pinhole. Intraocular pressure is 13 mmHg. Color vision and contrast sensitivity are normal. Evaluation of ptosis. In right eye, marginal reflex distance 1 is minus 2 mm and MRD marginal reflex distance 2 is 6 mm. Palpebral aperture horizontal is 28 mm, vertical height is 4 mm. Marginal limbal distance is 3 mm. Marginal reflex distance 3 is 0. LPS function through Burki's method is 4 mm. Bell's phenomenon is positive. Kogan-Litwich sign is negative. Lid fatigability is negative. Ice pack test is negative. Lid lag in down gaze is negative. Jaw winking phenomena is absent. Trans illumination test is positive. And lid crease is absent.
What is the LPS action? 4 millimeters.
4 milliliters.
4
Food,
millimeters.
sir.
Okay. Go ahead.
In left eye, MRD1, marginal reflex distance 1 is minus 2 mm. Marginal reflex distance 2 is 6 mm. Palpebral aperture horizontal is 28 mm. Vertical height is 4 mm. Marginal limbal distance is 3 mm. Marginal reflex distance 3 is 0. LPS function is 4 mm. Bell's phenomenon is positive. Kogan-Litwich sign is negative. Lid fatigability is negative. Ice pack test is negative. Lid lag in down gaze is negative. Jaw winking phenomena is absent. Trans illumination test is positive. Lid crease is absent.
What you have not mentioned? Width of palpebral aperture in all the 3 gauges should be mentioned in a case of ptosis.
Focus.
Right? Palpebral aperture in down gaze is very, very important. To know whether it's a aponeurotic ptosis or not. In acquired ptosis, it should be much narrower. MRD2, 6 millimeters, you said.
Yes.
Right?
Yes.
So,
Yes, sir.
with a 4 mm of LPS function and minus 2 MRD1, MRD2, MLD1, MLD is 3 millimeters, both sides. Okay, margin limbal distance. So, palpebral aperture and down gaze is very important here in this case. And how about lag of thalamus? Did you mention?
Lag of thalamus is absent, sir. I didn't mention.
Did you mention or not? I'm asking.
I didn't mention.
Then the second thing is, it's an elderly patient with a severe bilateral ptosis, needs surgery, right?
Yes, sir.
What would you like to know? What additional tests you would like to do? Drosing test?
Sir?
Drosing, phenylephrine.
Phenylephrine
Phenylephrine
okay.
test and also Skirmers. Because these people are elderly lady, can be a diabetic, can be already having a dryness. When you increase the palpebral aperture, they can go into severe dryness and may develop punctate keratitis.
Okay.
So if her Skirmers is low, say 2 millimeters or 5 millimeters, I prefer to do a little under correction, I'll put it a little above the pupil so that she can see clearly, and also warn them the need to use lubricant eye drops throughout the life. That we have to inform. Okay, so what's your diagnosis and how would you like to manage?
Sir, my diagnosis is both a severe aponeurotic ptosis. I would like to do frontally sling surgery.
Why frontally sling surgery?
Sir, leave it. LPS function is poor, sir.
Why? That's why I said, what is the mechanism of aponeurotic ptosis?
Maybe it is due to dehiscence or weakness.
So most often it is dehiscence or retraction of the aponeurosis. So when the aponeurosis gets detached mostly from the tarsus, what happens? There will be severe ptosis and the action may be reduced. What you all just need to do is levator resection. 4 millimeters is not bad.
Okay.
You can do under local a levator resection rather than a brow suspension. Okay. The
Okay.
disadvantage of brow suspension is lack of thalamus. Number two, if the width is more, you can go, the patient can go into dryness and associated symptoms. And the lack of thalamus is usually worse with brow suspension when compared to levator resection. So, in this situation, I prefer a bilateral brow suspension. Sorry, bilateral levator
Levator
resection.
resection.
This is the section that you can do.
Okay.
Right. And the
Okay.
second thing is, that's why I said width of the palpebral aperture in up gauge is important now. Suppose it is goes to 7 millimeters or something like that. It means the LPS can easily lift the lid up. So what you have to do is go to identify the levator palpebrae superioris, anchor it to the tarsus and see where is the position. If it is not up to your satisfaction, do a bit of levator resection also. So that you will decide on the table. So we call it as broadly levator aponeurotic surgery. We'll do either reattachment or associated with some amount of resection
Levator
also.
resection.
Resection also. That gives good results. Don't go jump for brow suspension.
Okay.
Okay, ma. At 4 millimeters levator function, even in congenital ptosis, levator supramaximal resections give good results.
Okay.
Supramaximal resection of levator gives good results when compared to brow suspension. 4 millimeters
Okay.
is this way, that way. 2 millimeters, 3 millimeters, we go ahead and do a brow suspension.
Yes.
Okay, Namu? What is Burke's rule?
Sir?
What is Burke's rule?
Burki's method. Ask the patient to look down and block the frontalis muscle and ask the patient to look up.
No, that is what you are saying is how do you test the LPS action? That is Burke's method of LPS action. What is Burke's rule in the surgery? That's where you keep the lid on the table. If the preoperative levator function is 7 or 8 millimeters, the lid stays where it is kept. So keep the lid 2 millimeters below the limbus, upper limbus. If the levator function is 10 millimeters or more, it goes up. Okay. So you do a little under correction. If the levator function is less than 8 millimeters, that's 6 millimeters, 5 or 4, it falls down after surgery. So keep it at the limbus. Keep the eyeball at the limbus. So where you keep the eyelid in relationship to the limbus depends on the preoperative levator function. Yet it stays where it is kept. If it's more, it goes up. If it's less, it comes down. Depending on that, you keep the eyelid position. This is called Burki's rule. Okay? Right.
Thank you.
You're welcome.
Thank you, sir.
Right.
Thank you, sir.
Very simple, straightforward case. So what else you could have done is, since you are presenting, it's not in the examinations, you can do a visual field and show how much of the upper visual field is obstructed
Okay, sir.
by the lead, ptotic lead. Right. Then what you can do, you can, with a tape, you can elevate the lid to the normal position, covering 2 millimeters the limbus, and repeat the visual field and show how much benefit the patient can get in way of visual field restoration in the upper arm. That is an exercise you can do. Okay?
Okay, sir. Okay, sir.
All right.
Thank you, sir.
Welcome, Amma.
Thank you,
Thank you.
sir.
We'll have
Thank
one
you,
more case.
Epo.
One more case is, go ahead.
Yes.
Process only, sir.
Oh, yes.
Ma.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you,
Thank you.
APOs, for giving this opportunity.
Well done, Tali. Good. All the best.
Thank you, sir.
Next, sir. Sushmita,
Yes, sir.
present your case, ma.
Yes, sir.
Make it a slideshow, ma.
Yes, sir. Good evening, respected doctors and panel members. Today we are going to discuss a case on topic ptosis. Myself, Sushmita, final year postgraduate from SVMC Tirupati, and my moderator is Shelpat Reddy sir, head of department from SVMC Tirupati. So, a chief complaint, a 56 years old male patient by name Raghunathayya, resident of Chittur, came to our OPD with chief complaint of drooping of right upper eyelid since 10 days. History of present illness. Patient was apparently normal 10 days back when he initially noted drooping of right upper eyelid initially while seeing himself in a mirror, which was insidious in onset and progressive in nature. It was not associated with defective vision in the right eye. It was associated with diurnal variability in drooping of the eyelid. That is, increase in drooping is noted as the day progresses. No history of double vision, no history of trauma, no history of difficulty swallowing, not associated with any variation of ptosis with jaw movements, and no history of any associated lid tumors or swellings or recurrent allergic conjunctivitis. Past history, no history of similar complaints in the past, and history of cataract surgery done in the right eye 2 months back at private hospital in Chennai. Coming to medical history, patient is a known case of diabetes, which is type 2 diabetes since 5 years and is on oral hypoglycemic drugs, tablet metformin 500 mg BD and tablet glimepiride 2 mg BD. And he is also a known case of hypertensive for the past 6 months and he is using drugs tablet Amlong 5 mg and tablet telmisartan 40 mg OD. Personal history, patient takes mixed diet, bowel and bladder habits are normal, sleep and appetite are regular. Coming on to general examination, patient has normal build and nourishment. Patient is conscious and cooperative. No evidence of pallor, icterus, cyanosis, clubbing, pedal edema or lymphadenopathy. On vitals, pulse rate is 78 beats per minute, which is regular. And blood pressure is 110 by 70 mm Hg in the right upper arm in the sitting position. Respiratory rate is 18 times per minute and temperature is febrile. And systemic examination, cardiovascular system S1, S2 heart, no murmurs. Respiratory system, normal vascular breath sounds and no added sounds. Abdomen is soft, no organomegaly. And CNS, no focal neurological deficits. Coming on to visual acuity, in the right eye, 6 by 18 with pinhole 6/9. In near vision, that is N18. Whereas in the left eye visual acuity, 6/18 with pinhole improvement to 6/12. Near vision is N18. And nasolacrimal duct syringing is patent in both eyes. And Schimmer's test basic at 5 minutes, that is 35 mm. And intraocular pressure in the right eye is 14 mm. In the left eye, it is 16 mm. And coming on to local examination, head is straight, face is bilaterally symmetrical, and chin is elevated. Coming on to ocular examination in the right eye, eyebrows are normal, eyelids, drooping of upper eyelid is present and lid crease is also present. Eyelashes are normal and palpebral aperture in the right eye, vertical height is 6 mm, horizontal height is 25 mm and MRD1 in the right eye is 2 mm and marginal reflex distance 2 in the right eye is 4 mm and marginal crease distance is 6 mm, marginal limbal distance is 7 mm. LPS function, which is recorded by Burke's method, which is around 6 mm. Lag of thalmus is absent. Bell's phenomenon is good in the right eye. Ice pack test, fatigability test, Cogon-Littwich test, curtain sign, Marcus. These are all positive in the right eye. In the ice pack test, there is a positive with 3 mm improvement in the ptosis is noted. Whereas in fatigability test is also positive and 3 mm increase in the ptosis is present. Whereas Cogon-Littwich and curtain sign both are positive in the right eye. And Marcus Gunja winking phenomenon is negative. This is a fatigability test, ice pack test. Coming on to cornea, right eye, size and shape is normal, surface is smooth, transparency is transparent, sensations are intact. Anterior chamber depth is peripheral anterior chamber depth is 3/4 of peripheral corneal thickness and contents are clear. Iris color is brown, pattern is wavy, pupil size 3 mm, shape round, reactions are reactive. And the lens in the right eye, there is pseudophakia with the PCO and extraocular movements are full in the right eye. Now coming on to left eye, eyebrows are normal, eyelids are normal, eyelashes are normal, palpebral aperture vertical height is 10 mm, horizontal is 28 mm, marginal reflex distance 1 in the right eye is 5 mm, marginal reflex distance 2 in the left eye is 5 mm, marginal crease distance is 7 mm, marginal limbal distance is 9 mm, LPS function which is noted by Burke's method is 13 mm in the left eye, lag of thalmus is absent, Bell's phenomenon is good, and ice pack test, fatigability test, Cogon-Littwich, curtain sign, and Marcus Gunja phenomenon all are negative in the left eye. And size and shape are normal, surface is smooth, transparency transparent, sensations are intact, cornea is normal. And left eye anterior chamber depth, that is peripheral anterior chamber depth is 3/4 of peripheral corneal thickness, contents are clear, iris color is brown, pattern is wavy, pupil left eye 3 mm, round, reactive, lens, we can see here there is grade 2 nuclear sclerosis is noted and extraocular movements are full. These are the picture of extraocular movements, it's all are normal. Next, coming on to fundus examination. In the right eye, media is hazy due to posterior capsule opacification. And the right eye, optic disc size and shape are normal. Color is pink. Margins are defined. Cup is to 0.3:1. Vessels, generalized arteriolar narrowing is bliss. Arteries to venous ratio is 1:3. General background, dot and blot hemorrhages are noted in the superior temporal quadrant and macula is plus, that is FR plus. Whereas in the left eye, media is hazy due to lenticular sclerosis, optic disc size and shape are normal, color pink, margins defined, cup is to disc 0.3:1, vessels generalized arterial or narrow, arteries to venous ratio is 1:3, and in the general background in the left eye, dot and blot hemorrhages are noted in the superior nasal and superior temporal quadrant, with hard exits are noted in the superior nasal and temporal quadrants, and macula is FR plus. So from this fundus, there is a both a moderate non-proliferative diabetic retinopathy changes are seen. And then we undergone with the test because in our setup, hydrophonium or tensilon test is not available. So then we proceed with a neostigmine test, which is positive, which is done as 1 mg of neostigmine is given intramuscular and waited for 10 to 15 minutes and the improvement is doses is noted in 15 minutes. And by this, my probable diagnosis, right eye, acquired myogenic ptosis with pseudophakia with posterior capsular opacification with moderate NPDR. In the left eye, grade 2 nuclear sclerosis with moderate non-proliferative diabetic retinopathy changes are noted. Sir.
Now, what are the types of myogenic ptosis? Why did you say acquired myogenic ptosis? When you have given all the features of myasthenia, why did you say myogenic?
Yes, sir.
What are the different types of myogenic ptosis?
Congenital and acquired, sir.
I
Acquired
am
is
asking
secondary to
myogenic.
myasthenia. Yes, sir.
What are the different types of myogenic ptosis?
Muscular dystrophy.
What are the
Myopathy,
different
sir.
types, Cheppamma?
Congenital and acquired.
Okay, carry on with your classification. My question is simple. What are the types of myogenic ptosis? You said acquired myogenic ptosis. You mean to say not a congenital
Sir.
myogenic ptosis? Now, the two things that are with your diagnosis, number one, there is no need to do the neostigmine test when clinically it is positive for ice pack and fatigue. When all the clinical
Yes, sir.
tests are positive, don't do a neostigmine test or
Yes, sir.
hydrophonium test. We have almost stopped doing them because it can cause complications. Patient
Yes,
will not be comfortable and you are not gaining anything extra. Okay. Instead, what's the role of an ophthalmologist in case of a myasthenia gravis?
We can use after.
What is your role?
Any sub-syndrome such as Kearns-Sayre syndrome, any systemic disorders to rule out, sir.
No, how does neostigmine help in that?
No, sir, in that neostigmine.
Because your CPEOs, ice pack test will be negative. Right. And CPEO after
Yes, sir.
motility will also be restricted.
Yes, sir.
CPEO is always bilateral. No diurnal
Bilateral.
duration. Here you are seeing a patient with 10 days duration, unilateral. Why do you think of CPEO?
Ocular movements and
Ocular movements are normal, isn't it? This patient.
all normal, sir. All.
It's a clear-cut typical case of myasthenia gravis. From the history onwards till the findings, everything. So in these situations, there's
Yes,
no
sir.
need to do the neurostreatment. What I
Okay.
do is personally, I refer the patient to neurologist for further investigation, which could be single muscle EMU, antibodies, or it could be CT chest to rule out thymoma.
Any thymomas, yes.
Yeah. And refer the patient to a retina specialist if necessary for the retinopathy. Or take care of it. And advise him regarding
sir.
that. I can understand if you ask for a OCT or a fluorescein angiography. rather than you
Yes,
test
sir.
in this.
Yes, sir.
Okay. So the
Okay, sir.
management is still referred to a neurologist. He will take
Sim-
care of putting on your signal or something, whatever it is. He will
Yes.
investigate and decide. If there's a
Okay,
time
sir.
he will take care of that.
Okay, sir.
Okay. So you have
Okay,
three variety of doses, three cases, different cases with different varieties. Good. And you should have read, just gone through my class on choices before you present, because you will be knowing my questions. It would have given you what questions I
yes.
will be asking, and you could have easily answered them. Okay.
Okay, sir.
Okay. Good presentation.
Thank you, AP Boys, for giving me the opportunity, sir. Thank you, sir.
Right. Thank you.
Thank you, sir.
If, if there are no questions or comments from the faculty, if there are none, I think probably we may close the session.
Sir, one more presentation. Is
Please,
there.
go ahead, please.
Sir, thank you.
Good evening, sirs and panel members.
Good evening.
Myself, Srilata, sir. I'm final year postgraduate in SVMC Medical College. My moderator is Dr. Gnanaprasuna Madam. Today, my case presentation is about a 62-year-old female by name Ratnamma, who came with a chief complaint of drooping of the right upper eyelid for the past 4 years. And it was gradual in onset, slowly progressive over the 6 months. It was associated with defective vision in the right eye. No history of double vision, not associated with any diurnal variation in the drooping of the eyelid, not associated with any variation of ptosis with the jaw movements, no history of any associated lid tumors or swellings or recurrent allergic conjunctivitis. And the past history, the patient had similar drooping complaints in the left eye, for which she was underwent surgery for the 4 years back. So both eyes she's having ptosis since 4 years. And that got operated 4 years back. And there is a history of cataract surgery done 10 years back. So on a gist, she had underwent cataract surgery 10 years back. Since 4 years, she's having the drooping in the both eyelids, and one eyelid got operated 4 years back. And her complaint is in right eye now. So the past medical history, she is a known case of hypertensive using tab atenolol 50 mg for past 3 years, and no history of diabetes, stroke, tuberculosis, asthma or chronic cough, epilepsy and cardiac illness. No history of usage of immunosuppressants or any anti-tubercular, antiretroviral medications. And her personal history, it's a normal appetite, normal bowel and bladder habits, and normal sleep pattern, and no positive family history. Her general examination, patient was normal, built and nourished. She's conscious and cooperative, and there is no evidence of any pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy, and her vitals are stable. Other systemic examinations like CVS and respiratory system are normal. Abdomen is soft and no organomegaly. CNS, no focal neurological deficits are seen. So coming to the ocular examination, visual acuity, right eye it is 4/60 with pinhole 6.9, left eye 6/60 with pinhole 6.9. And her NLD syringing in both eyes, it is patent. Schimmel's test, right eye it is 23 mm, and left eye it is 16 mm. Left eye, she underwent ptosis surgery. So on local examination, head is straight, face raised, eyebrows on the both eyes is seen, and chin is elevated. So coming to the eyebrows, both right eye eyebrows is elevated, ptosis is present and iris is seen. Eyelashes are normal. Palpebral aperture, vertical it is 3 mm and horizontal it is 28 mm. MRD1 it is -3 and MRD2 it is 6 mm. Marginal crease distance is 15 mm and her LPS function is poor through the Burke's method. So 4 mm it is. Lag of thalmus is absent in this eye. Transillumination test, Bell's phenomenon is present and it is good. Transillumination test is positive. IcePack test is negative. Fatigability test is negative. Kogan-Litchfield test is negative. That rule out some myasthenia or myogenic causes. And coming to the left eye, the eyebrows are elevated, which is operated. Left eye, eyelids are elevated and there is a small tenting in the left upper eyelid. Her palpebral aperture vertical height is 11 mm and horizontal it is 28 mm. MRD1 it is 5 mm and MRD2 it is 6 mm. So marginal crease distance is 3 mm. Her LPS function is also poor, 4 mm. Lag of thalmus, there is mild lag of thalmus in this patient. And Bell's phenomenon is good. Transillumination test is positive. IcePack test, fatigability test and Kogan-Litwich tests are negative, ruling out the other causes. Cornea size, shape, surface, transparency and sensations, everything is normal in both eyelids. So coming to the anterior chamber depth, both eyes are pseudophakic. Anterior chamber depth, PACT is 3/4 PCT in both eyes and contents are clear. Iris in both eye, it is a brown color and with wavy pattern. Pupil in both eyes, size is 3 mm, shape is round and reactions normal. Lens, both eyes, it is pseudophakia with PCO and extraocular movements are full. This is extraocular movements picture depicting. Coming to fundus examination, right eye media is hazy due to PCO. Optic disc size, shape are normal with pink in color, defined margins are there with cuppage to disc ratio of 0.3:1. And vessels, there is generalized arterial narrowing and venous dilatation is seen. A to B ratio is 1:4. General background, there is extensive choroidal sclerosis and macula, there is fovea reflex is dull. Coming to the left eye, the media is hazy due to PCO. Optic disc size and shape are normal with pink color and defined margins. The cuppage to disc ratio is 0.3:1 and generalized arterial narrowing is there with venous dilatation. Arteries to vein ratio it is 1:4. General background, there is extensive choroidal sclerosis and macula FR is dull. So my probable diagnosis is right eye there is severe aponeurotic ptosis with pseudophakia and PCO. Left eye it is status post-otic surgery with pseudophakia and PCO.
Okay. Again, the same. Everybody, you are not examining the palpebral aperture in the three directions. In the three gazes, up gaze, down gaze, apart from straight gaze. That's must for every case of ptosis evaluation.
Ptosis,
Nobody
yes,
has
sir.
done that. All the 4 you have not done. You make it very, very important. Right? What type
Yes,
of
sir.
surgery she underwent for the left eye?
It is a frontalis link, sir.
How do you say that?
Sir,
How did you say it's a frontalis sling surgery?
yes, sir. Both suspension surgeries.
So, did you feel any of the fascia lata or sling? Or are there any incisions above the brow, on the forehead?
Sir, above that incision scars can
Are
see, sir.
they? That you should have
Yes, sir.
mentioned.
Yes.
You should have mentioned without asking.
Yes. Yes.
Okay. So second thing is, as I said, 4 millimeters are LPS function. You can still do a good levator resection so that there won't be lag
Resections.
of thalmus, there won't
Lag.
be lid lag on down gauge.
Yes,
If
sir.
the patient
Yes.
looks down, is there any lid lag on down gauge? That we would have known
Yes.
only if you have said the width of the palpebral aperture on down gauge, which you have not mentioned.
Yes.
Okay.
Yes, sir.
So, what will you do for the right eye?
So right eye levator function is poor and severe ptosis is there. Still, we can go for levator resection now.
I prefer elevator second because the same point was already discussed with the early speaker,
Yes, sir.
earlier speaker.
Yes, sir.
You have to do elevator resection for the right eye, and also I don't mind doing it for the left eye because in the left eye you can see there is a contour deformity.
It
There
is
is a
tented.
peaking in the center. The contour is not great.
Yes, sir.
That can also be
Yes, sir.
corrected, but in view of her age, we can leave it to her
66.
discretion. That's very, very important. Cornea is good. You said there is a lag of thalmus. You didn't mention about lid lag and down gauge. In lid creases, I can see even when it is very small, multiple lid creases. At least 2 lid creases I am able to see in that small picture in the right eye. So usually remember that
Sir,
in case of aponeurotic cases, the characteristic feature is that there will be multiple lid creases, severe ptosis, usually with fair to good levator function.
Yes,
That will be there usually. Right? So
yes,
what
sir.
is
Yes,
the
sir.
MRD1 minus?
Minus 3, sir.
Minus 3 is the MR minus 3 millimeters. So with a LPS function of 4 minus 3 that can be easily taken care with a good levator resection surgery.
Levator resection we can.
Yeah, levator resection. 4 mm, even in congenital ptosis, we may do levator resection. Less than 4, it's brow suspension. But
Yes,
in
brow suspension.
aponeurotic ptosis, our preference is always for the levator resection. Depends on how much of the levator got detached and retracted. If most of the levator has got detached and retracted, you can sometimes see that the lid is very thin, and through the lid you can see the corneal contour and color also. In which
Yes,
situation?
transillumination test.
Yes. In which situation LPS function will be less? Because most of it has got dislodged from the tarsus.
Yes. Yes.
In those situations, just reattach the LPS,
LPS.
results will be fantastic. There is no
Yes, sir.
need to go for brow suspension. Okay, that will do. నేను చలపతి గారు ఏంటి ఇన్ని కేసులు ఆఫ్ కోర్సెస్ వచ్చాయి ఒక్కసారి మీ దగ్గర?
Sir, Madhu has requested to put variety of cases. So with starting from congenital, myogenic and aponeurotic.
అదే కంజెంటల్ ఎపోన్యూరోటిక్
అంటే
ఇన్వల్యూషన్
మీరున్నారంటే
మయోసిలియా
మొత్తం we want to share, present, sir.
బాగుంది.
Sir. Thank
Thank you, sir.
you,
Thank you,
sir.
APOS, for giving this opportunity.
థ్యాంక్స్ అమ్మా, యూ డిడ్ ఎ గుడ్ జాబ్.
Yes, sir. Thank you, sir.
Sir, thank you and good night, sir, for
గుడ్ నైట్ అండి, గుడ్ నైట్. థ్యాంక్ యూ. థ్యాంక్ యూ
Yes,
ఆల్
sir.
ద బెస్ట్ ఫర్ యువర్
Thank you.
ఎగ్జామ్స్.
being.
పిల్లలు,
Thank you, sir. Thank you.
ఆల్ ద బెస్ట్ ఫర్ యువర్ ఎగ్జామ్స్. గాడ్ బ్లెస్ యూ.
Thank you, sir. Thank you, sir.
రైట్ అండి, బై బై.
We'll
Everybody's gone.
ఉన్నాం ఇంకా తీసేసి మధు అని లేరు కదా. బషీర్ ఉన్నారా? బషీర్ గారు క్లోజ్ చేసేద్దామండి.